Hey everybody, my name is Jonathan Hancock. I am a nationally registered paramedic. I'm going to teach you guys about stop the bleed. We're going to be utilizing different components in this. This is going to be kind of more based towards EMT-Basics. So there's a little bit more things that we're going to add in that you're not really going to see in the stop the bleed, okay? So to begin with, we're going to talk about our objectives. First thing we're going to do is discuss the history of Stop the Bleed campaign. We're going to discuss different mass casualty incidents. We're going to discuss the Stop the Bleed procedures as to what their campaign is out there to do. We're going to discuss and practice direct pressure techniques, simplest way that you can control bleeding. Also going to discuss and practice wound packing techniques, discuss practice use of tourniquets, and we're going to have a brief summary at the end. So the question is, what is Stop the Bleed? So everything that we utilize within the medical, at least pre-hospital medical direction, is normally formulated by combat situations. They take research that is gathered within the combat situations and they apply it into pre-hospital. Because we are the closest thing to combat situations typically. We're the first people on scene, first line of defense towards everybody, okay? So what we have is, they've done many of those throughout the years. Now there was, one of the articles that was published was the analysis of the causes of death, casualties in field military setting. Now this was performed between 2002 and 2009. They found that gunshot wounds, of course, are typical, right? 63% of the time, they were hemorrhaging was due to gunshot wounds. Now, 18% of those gunshot wounds were preventable deaths. People who had died from those could have been prevented by just simple techniques such as direct pressure or tourniquet application, okay? So why stop the bleed? Why are we using it? So studies have shown the same thing all over the map. Just like CPR is. CPR is early recognition that the person needs, has no pulse. They need to be somebody pressing on the chest for them. Likewise with bleeding. If bleeding is stopped and it's controlled, then typically the person has a higher chance of survivability, okay? Now, unfortunately, the world that we live in today has gotten to the point where we have to utilize the same techniques that are utilized in combat situations. Tourniquet application, direct pressure, so on and so forth. It's very unfortunate where we stand now. Now, we've seen an increase in terrorist activity, also with active shooter situations over the years. Trauma can also be a factor to take into account. Trauma can happen to anyone, anywhere, anytime. So somebody who is working on your house, is remodeling your house, they could potentially cut or lacerate one of their arms to the point where they hit an artery. That would be the time that you're going to be utilizing your stop the bleed. However, what we're going to discuss and talk about is going to be focused mostly on mass casualty incidents, because for our situations, those are the big things where we have to know how to utilize our skills multiple times, okay? So here's a video from Arlington County Fire Department. They have a very good sense. I've talked to you guys before about how people want to help, and I just feel like this reinforces it just a little more. Sorry about that, it seems not to be working. That's okay, I'll just summarize what they're saying. So basically, there's a fire chief that comes on. He talks about how people are sitting around normally whenever we are the first people on scene. There's normally people helping out. There's a cat stuck in a tree or somebody's bleeding. People want to do things, okay? That's where Stop the Bleed kind of starts pushing itself, okay? They want people to know how to do things properly, because people want to help, but sometimes they can do more damage than good, right? How many people remember the Boston Marathon? Right. That's recent history, right? We remember kindly what happened. So just a recap of what happened. So during the annual Boston Marathon of April 15, 2013, there was 2 pressure cooker bombs that were placed just a few feet apart from each other. They were detonated 14 seconds apart for maximum damage. If they were detonated at the same time, they probably wouldn't get as many people as what they thought. So this killed 3 people, wounded 260 people, and of those, 16 lost limbs. So is this important that we know how to stop the bleed in these situations? Absolutely. And just a quick notation, no one actually died in the hospital. Everything whenever those 3 people did die, it was an instant death. Just look out the disbursement and carnage. I know I hate showing pictures like this, but it's just a realistic view of what really happened. So we have to actually take it in, because you may personally possibly be in these situations yourself. So the Orlando shooting at the Pulse nightclub. So now I'm sure everybody remembers this, don't you? Very, very recent. 2016, a shooter opened fire at a fully packed club. Now, he killed over 50 people. This is known as one of the greatest mass casualty shootings to date. One of them. Like I said, once again, very, very sad situation. Notice these bystanders, how they are willing to help. Like I said, it is a big deal. They're willing to help. Look, I mean, you can't ask for better people whenever the time is needed. The thing that you must do with these people is you have to direct them and give them a path in which to go. Holding cervical spine. Tell them just to hold their head in one place, right? It's kind of what he's doing right there. So some other MCIs, just to kind of notate, Oklahoma City bombing. So the federal building there in Oklahoma City, in '95, the truck was packed with multiple explosives, killing over 168 people, and hundreds of those were injured. You also have the World Trade Center. Of course, everybody remembers that fairly well. Recently happened to us, right? At least our anniversary did 19 years ago, or 18 years ago. 2 planes were piloted by terrorists, hitting the Twin Towers and killing roughly close to 3,000 people. There was also numerous amounts of injuries to go with that. The Las Vegas Music Festival. So October 1st, 2017, gunmen fired into a crowd, killing 59. That today is the highest mass shooting that we have on record. Hopefully there will be no more mass shootings, but unfortunately we live in a world where it happens quite often. So it's really pitiful. And also the Parkland shooting at the majority Stoneman Douglas High School, February 14, 2018. A gunman opened fire, killing 17. Like I said, these are a few. We can go through and we can discuss many of these situations. I just want to put it into light. Were all these in one place? Absolutely not. These were scattered across the nation. Unfortunately, you don't know if it could be your city could be next. Unfortunately, that's how it is. We have to prepare for what may come. So let's discuss the incident that happened that caused Stop the Bleed to come about. Sandy Hook Elementary School shooting. So 2012, December 2012, a gunman opened fire and killed 26 and wounded 2 others. 6 of those were students, 20 of them were elementary students. Sad situation, terribly sad situation. So what happened after this? This active shooter disaster prompted the committee headed by the American College of Surgeons, and they collaborated with all kinds of different people. It's amazing that these people are normally impossible to all get in one room to start collaborating. But the FBI, medical communities, representatives, national security, military, other federal governments all came together and they started discussing active shooter drills and mass casualty incidents. They came up with recommendations known as the Hartford Consensus. So the Hartford Consensus it has been added to and kind of renewed 4 different times. You have 2013, June 1st, 2013 is where it started. So they wrote an article that said improving survival from active shooter events, the Hartford, consensus. Then it was slightly revised September 1st, 2013, and they put intentional casualty events, and that was the Hartford Consensus 2. They went back 2 years later, and then they done the 3rd one, which is the implementation of the bleeding control, which is kindly where we're at now. Okay, so it's been a progression in steps, and now the latest is March 1st, 2016. They had a the 4th consensus, which is the call for increased national resilience. Okay, and that's where we stand as far as how our techniques are. So here's one of the posters. There's some big key takeaways that I need to point out here, okay? So ensure your safety. Do we do that? We are taught that as drilled in our heads, right? Must have safety. Your safety is first. Look for life-threatening bleeding. Assess life threats, right? Primary survey, right? That's what we do. We look for those life-threatening bleeding. Then, do we have anything that could help us stop the bleeding? So, yes, you start looking down through here. If you don't, use anything you got. So it's going to be clean cloth if you have it. I wouldn't be above pulling my shirt off and using it if that's all I had. Just utilize anything, okay? Then we work down here. If you do have stuff available, where is it located at? Is it the neck, shoulder, or groin? It's going to be different. Can we apply a tourniquet in those areas? No, we cannot. Absolutely. Now, what about arm and leg? Right on. Those are 2 places that we can apply that tourniquet. Okay. So our technique's going to be slightly different. So if that tourniquet is available for this area, apply it above the bleeding site, and then you tighten it down until it stops bleeding. We're going to talk about the tourniquet and how it's used and all that. Okay. And then pack the wound. Hemostatic agents are the best to utilize. Okay. If you don't have that, gauze will work, or just clean cloth. And then after that, we hold pressure down, okay? Letting it off ain't going to do nothing. Must apply pressure, okay? That's going to control that bleed even better than what it was. Here is the newest, latest, greatest campaign slide. Sorry, it's slightly blurry. Still kind of the same idea, right? They try to make it a little easier for the lay person to understand. Small pictures, quick words, all that. So apply pressure initially with your hands, and then work towards a hemostatic dressing. Then after that, work towards your tourniquet. And then they have wrap, line, secure, and then time. That's the process of which to do it. We'll discuss. We've already talked about it, but just to reiterate, direct pressure, pack the wound, then tourniquet application. We're going to go into each of those. All right. So this is directly out of your book. If this looks familiar, that's why. This is a step-by-step procedure as to how to do all this, okay? Foremost, take standard precautions. You have gloves, use them. Be very cautious for people you don't know. Remember, bloodborne pathogens are everywhere, okay? We're going to take, I say initially, gloved hand is a good pressure point to start, okay? So they're bleeding right here. Well, I'll just use this fella right here since he has a wound. So bleeding right here, first thing you want to do is go ahead and have your PP on. Just going to put 1 glove on just for demonstration purposes. I would have 2 if it was. Start there, okay? That is your first line of pressure control to stop bleed, okay? After that, we're going to utilize any type of sterile gauze if we have it, okay? Dry sterile gauze. Take that, put pressure on, put it nice and tight. Do we lift up the gauze? No, right on. I'm glad you guys know. We do not lift up the gauze, leave it where it's at, okay? If it starts bleeding through, does anybody know what you do if it bleeds through the gauze?
Just keep packing it.
Put another gauze on top of it, right? Keep holding pressure, okay? I will tell you, axillary areas, especially right here close to the femoral side, there is big old arteries that go through here, okay? So direct pressure is going to be intense. Say the laceration is right here, you may have to put your knee into that area. Combat situations, that's how they're trained, that they take their knee and actually lean into the patient and get good pressure. Believe it or not, some doctors in the operating room, if they have massive bleeding, they'll do the same thing. They'll get up there, bear their weight through their knee into that groin section, okay? You can utilize that method too, all right? So if it is not controlled, next thing we're going to move to, if it's on extremity, is your tourniquet. We're going to talk about those in a minute, okay? Tighten the tourniquet until the distal pulse are not palatable. So where's our distal pulse on an arm? Radial, right? Exactly, very good. So we're going to feel for that. If you can still feel radial pulse, is that tight enough? No, right, very good, okay. So tighten it until it's gone. Of course, with us, if we have the ability to apply oxygen, oxygen's good because they're lacking those red blood cells that's bled out. So whatever red blood cells are still floating around, we need to get as much oxygen on board as possible, okay? So there's a potential for them to develop what form of shock? Hypovolemic and hemorrhagic, right? So you kind of got those two because the pipes are getting drained, right? It's a lack of volume. Packing the wound. I do not, there is no, there's not one product that's used over another, okay? I'm not being biased in any way, okay? The reason why I use Celox is because that is what we utilize in our service. However, there's other ones out there, so don't, just because you see Celox, don't think, oh, that's the only one that we're going to use. There's other ones out there, okay? So this is directly from the Celox website. So they have, you see how this is kind of folded up into a Z pattern? There's a purpose for it. I do not have any of those Celox, otherwise I would show you guys how to do it. We're going to show you guys the next best thing, which is the a bulky dressing. Okay, the idea, concept is still going to be the same. Doesn't really change. Okay. So what Celox says, this is what it does. So Celox works independently of the body's clotting mechanism, unlike combat gauze. It is an inorganic material-based gauze product, and it works on hypothermic blood that does not clot normally, often found in serious casualties. I will tell you though, they may not even be hypothermic. They could be normal body temperature. This stuff still works really good. So remember we discussed this one key fact. We must keep our patients warm, right? Whenever they are starting to show signs of shock, their body isn't working. More so whenever we're talking about somebody who's bleeding out, okay? Everybody got that? And this isn't going to work either. That's okay. Quite all right. That's my luck. It is. So this was from EMT Prep. If you guys don't know about this, learn it. Okay, get on there. They have excellent websites. Okay, their YouTube channel is fantastic. They have all kinds of great stuff that help with testing and stuff. Okay, so they were going to show a video. However, that's okay. I can certainly do it myself. All right. So. Let's see. So let's talk about it. Crystal, can I have you come up here and help me, if you don't mind? All right. So we have our mannequin here. He has gunshot wounds to his arms and legs. Now, this isn't the only process in which we can patch a wound. There's just some gloves right there now, because we always take standard precautions, right? PPE always. Okay. So I'll show you guys the technique. I learned this from a tactical trainer course, combat trainer course. It works very well, works excellent this way. So first thing you do is you take this, roll it out. Now, are we worried about keeping the patient clean as much as saving their life? So infection is something that they can treat in a hospital, okay? However, them bleeding out profusely, we need to handle that because they're not going to be a patient to get the antibiotics, okay? First thing you do, you roll that out as such. You take this first part, wad it up into a ball, okay? It's called a power ball. Got that? Take that, shove that sucker down in there nice and good, okay? Then once we get that, we hold pressure with one finger, take the other side, wrap it, push it in. Hold the other hand, wrap it, push it in. Take the other side, wrap it, push it in. All that time, we are not taking our hands off the pressure point. Does that make sense? That helps with the clotting factor. We need to stop that bleed as soon as possible, okay? Then keep going, keep going. Say you pack it out, there's nothing more to do. Take what's left, throw it on top there, hold down nice and tight. Is this gonna hurt somebody? Oh yeah. It's gonna hurt them, but it's gonna save their life. They're gonna feel that pain if you got your fingers down in their wound and you're packing away at it, holding pressure, it's gonna hurt. Warn them, let them know, tell them this is gonna hurt. However, this is the only way that we're gonna be able to save your life. Okay? Got your PPE?
Yeah.
Right on. Good. I'm gonna let you do the arm since I already done his leg. So what's the first step? Do you remember? Yeah. Make a ball. Very good. Excellent. What do you do after that? Pack it in. Start shoving it in. That's right. You can just roll that sucker out. All right. So use your fingers if possible. Thumb's fine. Anything that you can do. Just keep packing it. There you go. And wrap and press. You can use alternate hands is usually the best method. Pack that there. Yeah. So you take one hand, pack it in. Very good. There you go. And take this other hand, wrap. Good. Push. Is it packed as tight as it can? Good. Okay, what do you do after that? Very good. Slam that on top there. Apply direct pressure. Excellent. Very good. Good. All right. Do we take this off?
No.
Right. Very good. Do not take this off. You can use like a Coban to apply the pressure. However, I prefer you guys keep pressure on there, okay? Keep it on there continually. Would a tourniquet be a good idea if it was somewhere on these legs to go ahead and put on? It's not going to hurt, right? We can go and have it ready. If this ain't controlling it, if it's still bleeding, tourniquet it is, all right? Do we install a tourniquet above or below the wound? Above. Above. Very good. Thank you. I appreciate your help. Excellent. All right. All right, so let's talk about some tourniquet stuff, okay? So we have different types of tourniquets. We have your improvised tourniquet. Now the improvised, it works okay. It works better if you have a windlass. What is a windlass, right? What the heck is that? The stick on the outside right here. So look at your tourniquets. Everybody's got one, right? Good deal. So this is your windlass. This is only used after you tighten this down, okay? That's the whole purpose. Like I said, we'll go over later, application. I'm going to torture you guys and let you put them on each other. Yay! So exciting. It doesn't fit, it's not comfortable. Not comfortable at all. Some key takeaways from this also is that these must be at least 1.5 inches wide, 2 inches preferably. If it's anything less than that, it's been shown that is less effective. So ideas that people use, like small cords, that's not very effective. It needs to have a wide surface area to press down on. All right. The tourniquets, oddly enough, have been around since 600 BC. That was the first documented history that they showed. So they've been around for quite a while. The first battlefield, I believe that was documented, was like in 1640 something. French surgeon decided to make a improvised windlass device like that. So if you do not have a windlass on it, how effective? Like what percentage is it going to work? Any numbers? 99% fail rate. It's only 1% it's going to work. Ain't that insane? That is crazy to me. I looked that up. I was like, wow, I did not even know. However, if you use a improvised device, it is closer to about 68% effective. So would you use an improvised device if you have nothing else? Absolutely, right? Now, it's no substitute to this. One or the two, this one's going to win out. Okay, it's way more effective. It's constructed the proper way to do the job. So some other devices that's out there. Now, whenever we show these next couple of slides, they use different as far as the way it's made. It has a turn device on it that tightens down. You also have the cat device, which is what you guys have. It's a little bit different as far as the design. I like these better. Okay, there's less things to go wrong with it. Okay, a little more work as far as it's concerned, but I feel like they're way more effective. Personal preference. You can do the studies for yourself. The next one is the soft T. Okay, that's what they call soft T. Now this is a very similar design, however, that doesn't have like the C-clamp design. It has like a triangle metal clamp that goes over that slides in, locks in place. Then it has a turn screw to even more tighten up the area to make it even more effective. So it's a little bit different, but like I said, these are usually used more often. The beauty behind this can be self-applied. So if you are getting shot, you can slide it on. You can take it, tighten it down yourself, nice and tight, and just start turning away. I guess that will do it. Whenever you use these devices, it's wonderful. Whenever you use these devices, like I said, you should have a loss of peripheral pulse. So down there, the very distal portion. Be sure to get this and wrap this up. I kind of made a mistake. This should be kindly underneath, like so, to keep it from flopping around. Document the time too, okay? It's going to hurt initially. However, after a brief moment of time, typically you start kind of losing feeling in that area, so it doesn't hurt as much. Now, is it still going to hurt? Oh yeah, it's still going to hurt. Just not as bad. Like I said, it's better than bleeding out. Much better. You'll start going numb, everything. You won't be able to feel it whatsoever, okay? All right. So, any questions about those? Okay? Well, let's look at the process, okay? So, after direct pressure is not effective, it's still bleeding through all your bandages. That's going to be your indication to work towards that tourniquet, okay? Where can we apply tourniquets? Anybody? Arms and legs. Can you put it on the neck? No. Thank you. Absolutely not. All right. So this device, the mat device, like I said, mechanical advantage tourniquet is what it's called. Pretty much all you do is you cinch that thing down and you just keep twisting, and that has a little clicker and it locks it in place. And once it's locked in place, it's good. So we want to look for two different things: bleeding is stopped, and then peripheral pulse is absent. Those are your two indications that it is good and tight. We need to reassess what we do, right? So go back sometimes, make sure it's not still oozing, or make sure the pulse is still absent, okay? Once again, this is a video I wish would play. This is Dr. David King. He's a very smart man. I can't tell you all his credentials. There's a lot, just a numerous amount. He's a surgeon. He's very much pro tourniquets, all about it. He needs to go through the process of step by step how to apply it. He has his less than 15 seconds. I assure you, you could even beat that. You can go a lot quicker, even with a little bit of practice. Okay, but look him up sometime. David King. Like I said, I wish it would play. Unfortunately, I know this isn't working right now. So, oh, let's go back. Woo, hold on. Don't look at that. Don't look at that. Hold on. Okay. You, sir, come up here and help me out for this. All right. Close? Yeah. Remember, PPE always, right? PPE always. So you, sir, this is going to be it's going to be an arm or a leg. Doesn't look completely like an arm or leg, but it's pretty close to it, is it not? It's good enough. All right. So here is your device. So what I'd like for you to start out at is, I want you to start at direct pressure, and then if that doesn't work, I want you to move to this. Your bleeding point is going to be right in this area right here, right in the center, okay? It's going to be your location. And this is going to be your proximal, this is your distal. So if they are bleeding right here, where are you going to apply? Just above it? Very good. Okay, it's bleeding right there. Go ahead and do your thing, and I'll have the blood flowing, all right? All right, blood flowing down there? Yep, all right. We'll see how you do, sir. Go ahead. All right, no bleeding is not controlled. Yep. So in his case, he'll have to actually undo it completely. Anybody timing him? No, I'm just kidding. You don't have to. All right, nice and tight. Excellent. Very good. Not. There you go. All right. Yeah. You can just leave that. There you go. You can just leave that off there for now. And then go ahead and start twisting. Does anybody see the bleeding? Has it stopped yet? Still not stopped. Still not stopped. Oh, what's going on? All right, let him loose. Let's try to redo this. So just go and let that out. You shouldn't have to turn more than 3 times. Okay. If that be the case, then maybe we need to loosen it up and tighten it down really good. Yeah, that's where it was, right there. So take that and pull that as tight as you can, and then go up right there. You don't have to leave it. Now start tightening. Okay, you've stopped the bleed. All right, so now the bleeding has stopped. So what do we need to check for after that? Pulse, okay. Feel for a pulse. Is there a pulse? Not a pulse. Very good. You've done extremely well. Fantastic. What's some other things that we do, like I said, whenever we apply it? Time, right? Thank you, sir. I appreciate your help. So why do we write down time? That's sometimes what people may ask. Why is that such a big deal? It is a big deal because whenever we take it in for surgery, we need to know how long that has been in place. It's going to change the dynamic about how that surgeon's going to act. Okay. However, now have you guys ever heard the ideas that it's leaving a tourniquet on too long is going to kill that limb? Anybody heard that? Okay, so that has kind of been slightly debunked. Okay, it's the studies have actually shown that it takes a long time before that limb actually starts dying. There's usually enough perfusion in that area to where it'll still be good. I think the last study I've seen was about 4 hours, and even longer is what some of them are saying. They used to say the old school method was you take these, and whenever you get for about an hour or so, you need to go, or 45 minutes, loosen it up slightly with the limbless and see if it's still bleeding. If it's still bleeding, tighten it back down. Then check it 45 minutes later, loosen it up and reperfuse everything. If it's still bleeding, tighten it back up. They were showing that was causing more damage to that area where it's twisting and turning. Okay, so they kind of said, let's not do that no more. So, all right, questions about tourniquets? You guys are going to get to apply your own. Yay, exciting. Okay, who wants to apply it on themselves? Anybody for that? It's a good, everybody's like, oh man, no, I don't want to do it. This is a good thing to know how to do. The reason why I say that is because you never know, hopefully you never get in a circumstance where you're going to have to apply it yourself. What I would tell you though is to have your tourniquet made in such a manner to where it's easy to get to. The way I store my personal ones is like this. I have it folded out to where whenever I get a hold of it, I can use one hand, take it like this, say this arm is just not working or it's absent, just slide it on there, and I can take this with one hand, pull it against it. Now the thing that you need to worry about is whenever you start using this windlass, especially if it's high up in this area right here, is that if the windlass is too far in, you'll start bumping against anatomy. So you may have to move it outwards just a little way, more on the lateral side of things. But the biggest thing that you need to do is you need to tighten this thing down as tight as you can when you first get it, okay? Nice and tight. So like I said, I like to go cinch it, then tighten it. Let this flop, that's fine for now, but we'll secure it later. You shouldn't, like I said, more than 3 twists. 1, 2, 3. I'll do it twice. You've already got yours applied, I see. Good. One time. Let's do it 2. That doesn't hurt enough. Ooh, how does that feel, everybody? All right, remember, it's a big deal. Like if this pops out, we need to secure it, right? So if you can take this strap and you can fold it underneath that C-clamp right there, and then throw this over top of it, that's where it's at. Oh yeah, I have no pulse. Feel your peripheral pulse of your friend beside you and see if you can feel it. If you can't feel it, does that mean you're doing a good job? Right, very good. Okay, I gotta take one off. I'm on Winnie. Can't do it. Okay. Application to someone else is no different, okay? The thing that you may run into is that whenever we have somebody who has a tourniquet that's malfunctioning, can you use more than one tourniquet?
Yeah.
Absolutely, right? Now, some places will say go high and tight. Say the gunshot wound's right here, and you can't apply direct pressure, and it's still profusely bleeding. And you pack the wound, still bleeding through that. You move to high and tight, as high up as possible. And then they say from there, if that's not working, go just below it. Use a secondary. 3. Now, if you have to use more than 3, I assure you, it's not gonna. That's usually impossible. It works pretty good. Does anybody know how a tourniquet actually works? I did not talk about that. What's the idea? Just the concept, the pathophysiology. What's that?
Artery or vein.
Sure. So think about your bone, right? So look at my little thing right here. So say this is the bone right here. This is your vein. The idea is that this clamps and pushes that vein artery against that bone, causing that occlusion to stop and do it off. So imagine somebody who has big muscles or has a lot of adipose tissue. As you can imagine, you have to cinch that thing down and tighten it good, okay? The anatomy's still going to shift and it's still going to put the pressure where it needs to be, okay? Questions about tourniquets? Yes, ma'am.
If you run across someone who's put on, like a torn shirt with a stick or whatever, would you be putting it above it or below?
Yeah.
Depending on what they've done, or generally above it?
Yeah, absolutely. My suggestion was just go above it. Absolutely. Yeah, and that's the other takeaway. Like there's some that are saying just proximal or just above that injured area. Then you take the second one, you move it above it. So it depends on where you read. My preference is the way our protocols are written. You go just above it, 3 inches above the proximal area if you can. So if the gunshot wound's here, just got to go just about right there. And if that doesn't work, go the next one up. So if you have an improvised device that is not being very effective, then just move proximal to it and go ahead and slap that on there, okay? Because people will, they'll use belts, which, belts are, it's about the right width, right? About 2 inches or so. However, there's no good way to apply a windlass. A lot of people will take triangular bandages. I'll show you guys later how to improvise one, but hopefully you never will. You'll always have these at your disposal. These are fairly cheap, these CAT devices. You can get one, now they're not super duper fancy by any means, but you can go on Amazon for like 20 bucks to get that. Very handy devices, very nice to keep around. I keep one in my jump bag, JIC. You never know when you might roll on a car accident or somebody has an amputation. You never ever know, okay? So, questions? Very good, okay? All right. Since you guys already seen this, let's do it anyways. Let's talk about it. Okay. Pop quiz. Woo. All right. So when do you stop turning the windlass on the tourniquet?
When there's no pulse.
No pulse. Okay. What's that?
No peripheral pulse.
No peripheral. Distal pulse. Peripheral pulse. Very good. And what else?
And the bleeding stops.
Stop bleeding. Correct. So those 2 things. Very good. When do you remove the tourniquet? Right on. Right. We keep that sucker on there. So it's better, say they do wind up losing a limb, it's that life or limb situation, right? We go ahead and just, we got to save their life first. So when do you pack the wound? I'm sorry, yeah, when do you pack the wound?
After direct pressure.
After direct pressure is not working, right? Now, let me tell, I did not discuss this, but I wonder if anybody can maybe kind of get this out, because we discussed it in class before, so hopefully maybe you guys might remember. So where are some areas not to pack? Abdominal cavity is one, very good. Neck. So neck you can pack, but however, this is something I have read across all the studies, is be very cautious about packing it too much. Because what do we have right here? Yeah, you have your trachea, your windpipe, your airway. So you start packing on that thing, that could have potentially obstructed. Okay. So what other area outside the abdominal area?
Brain.
The brain, yeah. Typically it doesn't bleed very much, but yeah, stay away from
Have
that.
it open.
Yeah, just pressure only, absolutely. Cautiously pressure, light pressure, gently.
Can't pack where the femoral artery is, right?
We can, absolutely. Any junctional area. So here, here, all those areas. What about up here?
No.
You want to pack the chest? Absolutely not. So we have that occlusive dressing, right? We've kind of discussed that. That's what you want to work towards, okay? So any of the trunk right here, stay away from, okay? Chest, abdominal cavity, stay away. Junctional areas, right here, here, cautiously when it's closer to the neck, okay? Hopefully most of the time, as long as they don't nick an artery or a vein, direct pressure is adequate enough, okay? And also right here in the groin too, okay? Pelvis with caution, okay? Pelvis with caution. All right, so in summary, you are the difference. We've talked about this. So you could be the person that saves the person's life. Remembering that hemorrhaging is a big deal. Not controlling the bleed, people are going to die. So use what you got. Whatever resources you have. If you have that tourniquet, utilize your tourniquet. And I would tell you one more time that direct pressure first, packing the wound second, and then moving to the tourniquet. However, if you have to pack the wound, go ahead and have that tourniquet ready, at least in place. Okay, does that make sense? All right. I like to end this with some. One thing about the United States that separates us from a lot of countries is whenever we have a very terrible incident that happens, you would think that people would disperse and kind of go away in misery. It helps to unify us. It's an amazing resilience that we have in our society. So these are two pictures. This was the year after that bombing, the Boston Marathon, and this right here was after the shooting there at the Pulse nightclub. People came together. People became more united. Okay, so I want to leave you at least with some type of positivity there, because it's a very difficult thing to talk about. Any questions before we hang it up? All right, thanks guys. We'll talk about this some more. We'll do a little bit more practice, okay? Thank you so much.